Welcome to Massoudi Foundation. We have dear Dr. Massoudi here, and our talk today is about acoustic neuroma. Is a neurocancerous and usually slow-growing tumor that develops on the main nerve leading from your inner ear to your brain. Branches of these nerve directly influences, and also the causes of acoustic neuroma can be linked to the problem with a gene on chromosome 22. Hello, dear Dr. Massoudi. How are you doing?
Good afternoon, Dr. Assefi. I'm doing well, and thank you for having me.
Thank you so much. Dear doctor, we have so many questions from our audiences. One of them is that, what is an acoustic neuroma tumor?
As you briefly alluded to, acoustic neuromas, or more anatomically and correctly known as vestibular schwannomas, are a type of brain tumor that pose interesting clinical and treatment challenges, as well as represent a new frontier in the development of new hybrid surgical treatments as well as non-surgical treatments. Acoustic neuromas, otherwise known as vestibular schwannomas, are tumors that arise from the unchecked growth of the Schwann cell lining the Schwann cells that form the lining of the eighth cranial nerve, which is a mixed nerve of acoustic and vestibular origin. They typically grow from the vestibular component of the eighth cranial nerve. And as you mentioned, in some instances, the unchecked growth of Schwann cells on the eighth cranial nerve, on the vestibular nerve, has been attributed to problems on chromosome 22, where a particular tumor-suppressing protein that a gene on chromosome 22 codes for is not synthesized the correct way, and therefore this tumor suppressor protein is missing, and that is thought to be leading to the unchecked growth of the Schwann cells. Nobody really knows why this particular problem occurs that leads to the lack of production and synthesis of the protein suppressor, but that has been linked to the problems on chromosome 22. And then in about 5% of cases, vestibular schwannomas, acoustic neuromas, are seen in a genetic syndrome called neurofibromatosis 2, type 2. And these tumors typically occur bilaterally on both left and right, and they really comprise the minority of the cases of vestibular schwannomas. The great majority, about 95%, are considered sporadic and non-familial or really non-genetic. In the NF2 version of vestibular schwannomas, the disorder is autosomal dominant, so that means only one parent can pass on this genetic disorder. In general, when you look at all the brain tumors across the board, vestibular schwannomas comprise about 6% of all brain tumors. And the incidence of newly discovered vestibular schwannomas is about 1 in 100,000. And therefore, for instance, in the U.S., approximately 2,500 to 3,000 people get diagnosed with vestibular schwannomas every year. And the prevalence is approximately 1 in 2,000, meaning about 1 in 2,000 of our population in this country has this kind of tumor, vestibular schwannoma, otherwise known as acoustic neuroma.
And how do they present?
The typical way they present is gradual hearing loss. Sometimes the hearing loss can be sudden, but more commonly it's gradual over a period of several months to a couple of years. The other way these tumors can present is a ringing in the ear called tinnitus. Sometimes they present with lack of balance or inability to maintain balance, and sometimes they present with vertigo, which is a sensation of everything spinning around your head, and kind of the dizziness that the general public sometimes describes this as. So those are the primary modes of presentation of vestibular schwannomas.
Wow. And are these tumors benign?
They typically are. The great majority of them are benign, and they exert their deleterious effects through gradual and slow growth. And what happens is that as they grow larger and larger, they affect the adjacent auditory portion of the eighth cranial nerve and cause gradual loss of hearing or sudden loss of hearing. They can cause tinnitus and ringing in the ear by their gradual compression of the surrounding structures. Sometimes they grow quite aggressively, and they are associated with histopathological aggressive features. And in those instances, these tumors can grow quickly, affect the adjacent and nearby seventh cranial nerve and cause facial weakness. And at times they can grow all the way into the cerebellopontine angle where the anatomical location of these tumors is and begin to compress the brainstem and cause other neurological dysfunction. But that's usually rare. Usually they grow slowly and cause tinnitus and hearing loss by local mass effect.
And what are the treatment options for this type of tumor?
The treatment options vary, and frankly, it depends whom you go see and what center you get referred to. Some centers have a predilection and propensity to recommend surgery up front. Some centers recommend focused beam radiation, radiosurgery. My thinking on vestibular schwannomas is that it really depends on the mode of presentation, the rapidity with which symptoms are progressing, the age of the patient, and the size of the tumor. Generally speaking, these tumors can be monitored and managed what we call conservatively and expectantly. And if they do demonstrate a very slow pattern of growth over the years, and depending on the age of the patient, they can be just watched and really nothing can or should be done to them. If they begin to cause hearing loss and other symptoms, and they demonstrate MRI evidence of growth over a period of time, then focused beam radiation is a very viable treatment option. It's non-invasive, it's outpatient, and depending on the level of hearing, our ability and desire to preserve hearing, radiosurgical intervention can be single fraction or what we call hypofractionated, which means that the same radiation dose is delivered over a period of 3 to 5 days, or fully fractionated over a period of 28 to 35 days. And there's a variety of different evidence in the literature that suggests that when we're dealing with serviceable hearing or desire to maintain hearing, hypofractionating the radiosurgical intervention may be helpful in that regard and help us preserve hearing. When it comes to surgical intervention, again, the broad division surgical approach is ability and desire to preserve hearing versus resecting the tumor and eliminating the source of compression. Usually gross total resection of tumors, regardless of what the surgical treatment option is associated with complete and irreversible loss of hearing. And a lot of times the patients have no serviceable hearing to begin with. In my experience, resecting acoustic neuromas is obviously technically nuanced. And the intimate association of the tumor with the seventh cranial nerve and other vascular structures in the brainstem makes it a technically nuanced undertaking. And the great majority of complications associated with surgical intervention, I would say about 90% of them take place in the last 10% of the tumor resection. So I have, over the years, become a big believer in a bimodal treatment approach to surgical and larger acoustic neuromas, otherwise known as vestibular schwannomas. And that is, you go in and debulk the tumor using appropriate intraoperative monitoring, and the residual tumor then lends itself very well to either hypofractionated or single fraction adjuvant postoperative radiosurgical intervention. And I think in that sense, you debulk the tumor, eliminate the local mass effect, and reduce or eliminate the likelihood of the residual tumor growing again. So this kind of a hybrid approach of using surgical intervention in conjunction with postoperative adjuvant radiosurgery, I think would be a very effective way in many patients. What is exciting in this realm of acoustic neuroma and vestibular schwannoma surgery and treatments is a recent observation that Avastin which has been used in the treatment of a variety of different cancer disorders, colorectal, ovarian, advanced cases of cervical tumor, and even glioblastoma multiformes, is effective in reducing the size of the vestibular schwannoma and restoring or preserving the hearing that is associated with this problem. Avastin, as you know, is a vascular endothelial growth factor inhibitor. Essentially, it's a drug that starves the tumor cells by eliminating or preventing the formation of new blood vessels. So it's been effective in the treatment of other tumors, and it's been shown to have some promise in the treatment of vestibular schwannomas. And in fact, in late 2022 and early this year, a health center on the East Coast has applied for a phase 1 clinical trial where Avastin is delivered through super selective arterial infusion into the tumor, and it's been shown to decrease the size of the tumor and improve hearing. So this phase 1 of this clinical trial is going to be most likely underway shortly, and it shows promise, and it really conveys the hope and the possibility that the effective treatment of vestibular schwannomas can be it can be carried out much less invasively through an endovascular super selective arterial approach and infusion of Avastin into the tumor. We're going to be watching this development with excitement and closely, and this particular clinical trial holds some promise in altering the way we treat acoustic neuromas ultimately in the future.
Wow, that is great news. Thank you so much, dear doctor. It was great interview and great information from you. Thank you, as always.
My pleasure, Dr. Assefi, and thank you for having me.
Thank you. Everybody, please stay with us. We have so many great programs like interview with experts and great question and answer programs in science and also medical fields. Thank you. Please stay with us. Don't go anywhere.